Oh, yeah, that's not a good one
It
at
is
all.
too much. Even here, like,
What if we moved it to
do they have wireless microphone? Do we even need it? Oh, they're video gaming it, so. Good evening, everybody. Welcome to our patient forum. Thank you so much for carving the time out and to come and be part of continue to be part of our family. The Arthritis Society and the Canadian Spondylitis Association have teamed up this time to bring you this forum, Living with Ankylosing Spondylitis and Psoriatic Arthritis. My name is Ahmad Zabib. I'm the Executive Director of the Ontario Division at the Arthritis Society. And briefly, you will hear from Graham representing the Canadian Spondylitis Association as well. The Arthritis Society has been setting lives in motion for 65 years now. We're dedicated to a vision of living well with arthritis, and we're definitely working towards a cure sometime in the future. The Society is Canada's principal health charity providing education, programs, and support for people living with arthritis, which is, we're looking at 4.6 million Canadians. Since its founding, we've contributed over $195 million in research. We're Canada's biggest funder of research after the federal government. So we're really excited to bring you this forum, and I want to introduce Graham from the Canadian Spondylitis Association.
Good evening, everyone. As Ahmed said, my name is Graham Reed. I'm currently a representative of the CSA, the Canadian Spondylitis Association. The one thing about the CSA that's important is that it's volunteer-led. So, I encourage everyone here to get involved just like I am. The CSA is a national nonprofit association to advocate for and support those suffering from ankylosing spondylitis, psoriatic arthritis, and other associated spondyloarthritis conditions. Our mission is to create awareness and in order to ease the path on diagnosis. So my job tonight is to do a few kind of housekeeping things. The first thing is that I think everybody should have an evaluation form. We'd really like you guys to fill those out in order so that we can improve, so that we can reflect on how to do better practices. You were also given question sheets. So throughout the 3 presentations, I encourage you to write down your questions, and we're going to try to respond to those after the third presentation. As some of us suffer from AS, like myself, we encourage you to stand up and stretch at any point when you need to. Don't worry about sitting still for the entire 3 hours. We know how difficult that might be. And just washrooms are located basically directly outside of the hall here. So you just walk out the doors and walk straight down. My last job is to thank our sponsors again. So, we couldn't do this without Janssen, AbbVie, and Amgen. And I'll pass it back to Ahmed to introduce the 2 doctors.
We're really fortunate to have 2 very well-respected doctors from Ottawa area here with us tonight. It's humbling reading, the achievements of the doctors who are joining us, and I'm sure you'll find this their presentation is very helpful. Our first speaker is Dr. Jacob Karsh. Dr. Karsh is a rheumatologist at the Ottawa Hospital, He's trained in rheumatology at the Royal Victoria Hospital in Montreal, and then his postgraduate research training at the National Institute of Health in the States and Maryland. He's a full professor of medicine at the University of Ottawa. Dr. Karsh is the past chairman of the infection and host defense block of the medical undergraduate curriculum, teaching basic immunology. His area of expertise include basic immunology, pathogenic mechanisms in rheumatic disease, and it's a long day. The pharmacology of biologic drugs, NSAIDs, and other DMARD therapies. You'd think somebody who has a medical degree can read this information, but Dr. Karsh is the founder of, do you call it RU or RO? RU. So the RU Clinic, which stands for the Rheumatology and Orthopedic Clinic for the Prevention of Osteoporotic Fractures. Dr. Karsh has published about 100 manuscripts on various aspects of the arthritic diseases, including articles on the early history of corticosteroid therapy. He is the past secretary treasurer of the Canadian Rheumatology Association, vice president of the board of the Journal of Rheumatology, a member of the board of the Canadian Rheumatology Research Consortium, now disbanded, and former senior editor of the Canadian Medical Association Journal. He has been an external reviewer for Health Canada, the Canadian Drug Regulatory Agency, and is a current clinical expert for CADTH, the Canadian Agency for Drugs and Technology in Health. As you can tell, you know, if anybody knows about the topic, it's absolutely Dr. Karsh. Our second speaker is also very well decorated. She's Dr. Sibel Aydin. I hope I didn't sabotage the name. Dr. Aydin is a consultant rheumatologist at the Ottawa Hospital and associate professor at the University of Ottawa. After completing her medical school degrees in internal medicine and rheumatology in Istanbul, she went to the UK for her research fellowship, where she had a chance to work with the leaders in the field of psoriatic arthritis. Dr. Aydin has a special interest in the diagnosis and management of psoriatic arthritis. She runs a specialized clinic in this area at the Ottawa Hospital. She has more than 70 papers in peer-reviewed journals. Today. Her main research area is imaging in psoriatic arthritis and how ultrasonography can be used in earlier diagnosis, as well as clarification of the pathogenesis of the disease. Dr. Aydin has moved to Canada 1 year ago and has two sons who are 11 and 5 years old. Welcome to Canada, Dr. Aydin. So we'll start with Dr. Jacob Karsh, and then we'll move to Dr. Aydin after that.
So thank you for the nice introduction, and thank you all for coming tonight. I forgot to do this as well. Okay, so I started rheumatology in 1975, and my white hair allows me to talk a bit about the perspective and the change in the landscape over the last 40 years. And I can tell you that the landscape has changed dramatically for patients with inflammatory arthritis, whether we're talking about rheumatoid arthritis, or Ankylosing, or psoriatic arthritis, or the other spondyloarthropathies. So this picture would have been typical of a lecture I would have given in the 1970s, showing a gentleman with ankylosing spondylitis with the classic change in posture that occurred over the years, the inability to straighten the spine, looking at the floor, and I've had patients with much worse postures in the past. And in terms of the diagnosis of disease, it was purely a clinical diagnosis at the time. It dealt with low back pain, insidious onset. We'd like to get an onset below the age of 40, because after the age of 40, we start to get things like osteoarthritis complicating the ability to make the diagnosis. And it had the characteristic feature of pain worse with rest, a desire to get out of bed, not sleeping in, moving around, which helped control the pain. And in 1975, I can tell you, there weren't many medications available to do that. Mechanical back pain, that's a classic constellation of symptoms that we teach medical students to recognize, but even inflammatory back pain, patients with mechanical or degenerative problems have similar symptoms, so it wasn't an absolute way of diagnosing the disease. And then I would carry on with how it would progress, and as I said, it would progress to look like this here. And today I'd like to say that this picture should never occur again. And I think we have the medications to prevent this from happening. So a little bit about the epidemiology. Now in 1975 when I started, we didn't know anything about the genetics of any of the rheumatic diseases. These are findings that came out a few years later. So as I said at the beginning, it was purely a clinical diagnosis supplemented by x-rays. But the association of this gene, the HLA-B27 gene, and the variety of rheumatic diseases, particularly ankylosing spondylitis, really led to an improvement in our ability to understand the pathogenesis and to help in the diagnosis of the disease. Now, this gene occurs in about 8 to 12% of people in North America and Caucasians. It's rare in other groups, rare in Africa, rare in American blacks. The disease has a strong male predominance, but the gene is equally expressed in men and women. Yet there are certain differences that lead to the disease occurring somewhat more often in men, and also to the manifestations often being somewhat more severe in men. Onset of ankylosing spondylitis, and that's what I'll start with, generally is a young age, teens, early 20s. And if you have the gene, the likelihood of getting ankylosing spondylitis is low. It's only 1 to 2%. But if you have a family member with the disease and you carry the gene, the rate is around 20%. So there is something else in that family history that also leads to the development of ankylosing spondylitis, or identifying more genes. But still, there's a long way to go to understand the exact genetic contribution to the disease. This is what an HLA-B27 molecule looks like. It's on your immune cells, and how it interacts with your immune system to lead to the disease is still fairly obscure. How it interacts with the environment and the host in terms of leading to disease is obscure, but that's our predominant hypothesis. Sorry, I can't hear. Oh, is it? Okay, well, which is not an uncommon feature. So do we have a way of rescuing this? Can't tell you how often that happens. Before we got into this here, if you remember the days of slide projectors, can't tell you how often the light would burn out just as you were about to start. Okay, so we're saved. Okay. This just is for fun. It gives you an idea of the rate of B27. And one of the things you might notice is that it's very high in the circumpolar region in native groups, whether it's in North America or whether it's in Europe. And the rate of the gene can be as much as 50% in some of those populations. And if you look at this here, the rate of Ang-Spond is roughly about 10% of the rate of the gene. So in areas where the gene is present as much as 50% of the patient, the rate of Ang-Spond is around 5%. In our population, where it's about 8 to 12% of the population, the rate of ankylosing spondylitis is about 0.5 to 1% of the population. Meaningful number of people, rate of rheumatoid arthritis is about the same, the rate of psoriatic arthritis is about the same. At least 3% of our population suffer from these inflammatory arthritis, with all the things that that means in terms of medications, in terms of disability. Okay, so again, on a clinical basis, if you see somebody in the office, the complaint is low back pain, and if the pain has the characteristics of what we call mechanical pain, worse with activity, the likelihood that you have Ang-Spond is about 5%. If you get into the inflammatory back pain, it was about 14 or 15%. So back in 1975, before the presence of the gene and before our way of looking at things, the diagnosis of ankylosing spondylitis depended predominantly on X-rays, and we were missing lots of people with the disease. Today, in addition to X-rays, we have MRI, and we're now capturing a much larger population with ankylosing spondylitis. But you can see what the gene did from a clinical diagnosis, where the likelihood of having the disease was 15%. With the gene measurement, it was up to about 90%. So the power of the genetic association increased our ability to diagnose ankylosing spondylitis substantially. So today, if we are pretty sure about the presence of ankylosing spondylitis, and we can do that by history and X-ray, there's no need to do an HLA-B27 gene. It doesn't convey any more information, and there's a cost associated with that. The best place where the HLA-B27 gene comes into play is when you suspect ankylosing spondylitis. The X-rays are negative, and they often will be, and the gene will give you extra information to say you're probably dealing with a case of inflammatory low back pain. Okay, and this is an attempt to show you the areas that are involved in ankylosing spondylitis. So we're talking about the back sacroiliac joints, which are in your buttocks, the entire spine. The disease usually starts slow and goes up, but sometimes it'll start in the neck and work its way down. And then the other part, those blue things, refer to another feature that's increasingly being recognized and being understood, and that's something called an enthesitis. The enthesis is where tendon goes into bone, where cartilage and bone meets. It's just a single cell layer thick, but it can become the site of focus of an inflammatory cell reaction, and it is very strongly innervated so that it hurts. So people with this have pain and stiffness, especially stiffness around their pelvis. They ache in the pelvis, they're stiff in the pelvis. They ache in their shoulders, they're stiff in their shoulders. You don't see any swelling, but that's a common manifestation of ankylosing spondylitis and psoriatic arthritis. It's called an enthesitis. There'll be some that are more apparent, and I'll show you some slides later. So it is a spinal arthritis, it is a enthesitis, and sometimes you'll also get involvement of the core joints, shoulders and hips. And these just show you some of the bony changes with advanced disease, the changes that we believe we can avoid in the future with the use of proper medication. So the two diagrams on your right show you what are called syndesmophytes, and this is calcification in the intervertebral disc, the outer layers of that, which as it gets more and more calcified will lead to fusion of the spine. So the vertebra will fuse, some of the other smaller joints in the spine will fuse, and you get the classic picture of somebody who can't bend, can't touch the floor, can't get their head against the wall. And increasingly they bend forward and forward as time goes on. Okay. So that was 1975, maybe to about the year 2000, and this is how we envision ankylosing spondylitis and the spondyloarthritis today. So yes, we do have a time when there are X-ray changes, which you can see in these diagram. And people can meet the X-ray changes, which will say you have ankylosing spondylitis. If you go further, which you don't want, you see the spinal fusion. But we've since recognized on the left that there's something called non-radiographic ankylosing spondylitis. People who have the symptoms, people who don't have abnormal X-rays. Okay? And it is this group that we're now very much involved in dealing with. They can have MRI changes, so MRIs are important in diagnosing it, but not everybody with non-radiographic ankylosing spondylitis has MRI changes. Okay, so we are now hopefully dealing with the disease where it occurs on your left, long before we get X-ray changes, long before we start to see the fusion. And this is the stage now where we'd like to intervene with treatment and to prevent all those things from happening. And I believe we're doing that. Okay. So just to give you a sense of the proportion of people with obvious ankylosing spondylitis and non-radiographic ankylosing spondylitis, these are studies from various centers around the world dealing with ankylosing spondylitis. And it shows you the ratio between patients diagnosed with obvious ankylosing spondylitis and non-radiographic ankylosing spondylitis. And you can see that the shorter the median or the average duration of symptoms, the greater the proportion of people have non-radiographic angspond versus those that have gone on to develop X-ray changes. So you can see on the upper groups where the duration of disease is lower, you can see that 70 to 80% of people have non-radiographic, and in the lower series where people have had longer duration of diseases, you see that the majority have gone on to develop clear ankylosing spondylitis. And this gives you another idea of showing you that. It is the duration of symptoms and this ratio. So you can see the longer you have the symptoms, the greater the likelihood of showing radiographic changes. Starting treatment when you've got radiographic changes doesn't make any sense. You want to avoid those if you can. The other thing it shows you that even with long periods of, long durations of symptoms, you still may not have X-ray changes. You've been coping with the disease for 12, 15 years, and often with ineffective medications. And we'll talk about that as we go on. And coping is really what a lot of men, a lot of people with ankylosing spondylitis do. Okay. So this shows you the change. This is one of the German studies that looked at the progression, and it looked at a 2-year interval, people who came in with no X-ray changes to the diagnosis of ankylosing spondylitis based on X-ray changes. About 12% of people progressed in 2 years. And if you look at the previous slide, you can see that progression does occur over time. Progression is greater if you have inflammatory blood tests, elevated sedimentation rate and elevated CRP. So among the things we do when we see people is we measure these, which gives us some prognostic information about likelihood of progressing. Okay? And it's information we'd like to act upon in terms of determining which treatments we're going to decide. Okay? If you see a difference in progression between 7 to 24% based on the presence of inflammatory markers, you really would like to treat those people particularly at the higher risk of progression. We do not want people to progress if at all possible. And this is an older slide, but it really again says the same thing. The interval between the onset of symptoms and the diagnosis of disease is roughly 9 years on the average, but it can be really even much longer at that time. A long period of time when people are coping with the symptoms of ankylosing spondylitis. Okay. So how good is the MRI? Well, you can see that these are people who have no X-ray changes, and if you have an abnormal MRI and you did a biopsy of the sacroiliac joint, you can see that these people do show inflammatory changes. But interesting are the group below that who are MRI negative for sacroiliitis. So how are we going to deal with these folks? A good many of them have inflammatory changes on biopsy, but biopsying the SI joints is really not an easy thing to do and not something that we'd readily do. And what about the group who have a normal MRI and have no inflammation on biopsy? What are they? Are they ankylosing spondylitis? How are we going to get payers to actually agree to treat them? We're really dealing with the MRI positive group now, but in the future we're going to have to deal with the MRI negative group who have all the symptoms yet don't have any radiographic imaging. Okay? And just to get somewhere to the next step, payers want strong evidence of the presence of ankylosing spondylitis, which for a long time has required radiographic changes. I'm talking about your insurance company. If you're a senior, I'm talking about the provincial access to medications. They wanted to see X-ray changes. They are coming around and accepting MRI changes. But what about for the people who haven't even reached that? They still should not be allowed to have treatment which may help them. Okay. And this is what a biopsy would look like. Those little brown dots are lymphocytes, immune cells that are causing the process in the joints, which is what ankylosing spondylitis is. It's an inflammatory disease of joints and of the enthesis. Okay. So what's the impact? Well, the obvious impact of ankylosing spondylitis is that of fusion of the spine and limited mobility of the thoracic spine, limited mobility of the small joints of the spine, poor breathing, a rigid spine, a possible fracture, especially in rear-end accidents where people have just sheared right through that rigid spine, but also at a societal level, lack of employment, inability to work, disability. These are all impacts, all costs that we can avoid in the future if we can convince people who only are concerned about their budget for the next 6 months that it's worthwhile treating people and preventing problems that are going to occur 10, 15, 20 years down the road. It's been a tough fight. Okay. So how do we treat ankylosing spondylitis? SPARC is a consortium of clinics in Canada that's interested in the seronegative spondyloarthritis, which are ankylosing spondylitis and psoriatic arthritis. And they've made a few recommendations for treatment. The initial guidelines that SPARC had was in 2003. They've updated them more recently. And we'll talk a little bit about that, especially in ankylosing spondylitis, where the evidence is that the traditional drugs used to treat arthritis, like methotrexate and leflunomide, are totally ineffective in axial disease. Some evidence that using anti-inflammatory drugs can be disease-modifying, in other words, stop progression of X-ray changes. We'll talk about the newer biologic drugs which have really changed things, and about this entity of non-radiographic ankylosing spondylitis. Okay. So, treatment of ankylosing spondylitis, as I said, the drugs that we use to treat most types of arthritis, like methotrexate, leflunomide, a whole bunch of others, don't work for spinal disease, so you can't use them here. So those are the ones on the right. They're useful for psoriatic arthritis, rheumatoid arthritis, but not for spinal disease. What are we left with for spinal disease? Well, for a long time, when we didn't have many medications, a lot of effort was spent with physiotherapy, trying to maintain your posture, not sleeping on high pillows to maintain your posture, preventing your neck from moving forward, exercise to prevent you from leaning over too much and getting into a posture where you're looking at the floor. Those are all important. Self-help groups, some of you I'm sure are part of those, helping people coping, providing good advice on how to manage. And the use of, in axial disease, of anti-inflammatory medications. And for many years they were the mainstay. When I started rheumatology in 1975, which ones did we have? Well, we had aspirin. We had indomethacin. I don't know if any of you were ever on indomethacin. Not an easy drug to be on. We had phenylbutazone, the drug that was eventually banned because of some of the side effects. And drugs like Motrin and naproxen really started to make their appearance around 1980, late 70s, early 1980. So treating Angspon in the 70s, there really wasn't a lot. We didn't like to use corticosteroids for the various and obvious reasons. So we'd use anti-inflammatory drugs. One of the things that was apparent that there were a few other things that were useful to do, and one of the strongest ones was to stop cigarette smoking. Now, in rheumatoid arthritis and maybe in psoriatic arthritis, cigarette smoking is a very strong risk factor for the development of arthritis. We understand the mechanism where smoking interacts with inflammatory cells and eventually brings the immune system into play. Okay? But and if you look at smoking, it has a number of other deleterious effects. So if you look at Ankylosing patients, comparing smokers, past smokers, and current smokers, you can see that measures of disease severity are worse in smokers. That could be whether you're assessing stiffness, whether you're assessing the number of these enthesitic points, and there are a number through the body, whether you're assessing how well they can get their head back against the wall, whether you're assessing how well they can lean forward, and just how much mobility there is in the spine. And you can see there's a striking difference between smokers and non-smokers in all these measures. So, stopping smoking is important. I'm glad to say that fewer people smoke today. In 1975, 52% of Canadians were smokers. In 2016, less than 20% of Canadians are smokers. So at least that's had some impact, not because people were getting diseases. There are many other reasons why people stop, but it is an important thing. The other thing we've learned is that smoking makes a lot of our drugs less effective. Biologic drugs don't work as well in smokers as they do in non-smokers. So back to the treatment. So we use anti-inflammatory drugs. And there is a bit of evidence that if you use anti-inflammatory drugs on a regular basis, you have less progression of X-ray features. So this looks at people who are taking anti-inflammatory drugs every day, whether they're symptomatic or not, which is on the left, versus those who take them intermittently for symptoms. And the measurement is a measurement of progression of X-rays or of X-ray damage. And those who are regular users of anti-inflammatories compared to those who aren't actually would have less changes on their X-rays over time. Okay? So some positive things about that. The problem is that some of the better anti-inflammatory drugs are no longer on the market. And they're not on the market because of some of their heart issues. So in the last 10 years, we've lost Vioxx, we've lost Prestige, we've lost Betstra. We've lost about 4 or 5 anti-inflammatories. We're learning that some of the other ones are still available, are just as bad for the heart. They're still available, though. Health Canada hasn't decided to take them off the market. They just have not allowed some of the newer ones. Whereas in Europe and most of the world, some of these anti-inflammatory drugs are still available. So what do you need to do with an anti-inflammatory drug? Well, in order to go forward, most countries, including Canada, payers have said, well, if you fail 2 anti-inflammatory drugs, then you can be eligible to go on to a biologic for ankylosing spondylitis. And what does failure mean? Well, it just means a 2 to 4 week course. People know if an anti-inflammatory drug is working in 2 to 4 weeks. You don't have to be on it for 3 months or longer. If it hasn't worked in 2 to 4 weeks, it's not going to work for you. Okay? So then the drugs we tend to go to, because we have nothing else, are the biologic drugs. Okay? So that defines an inadequate response to an anti-inflammatory. So as I said, there's no evidence for efficacy of the traditional drugs in spinal disease, and that the biologic drugs, and for the most part the TNF inhibitors, because those are the only ones that are available until very recently, would be the ones that we would use. We might make a few selections based on some what are called extra-articular manifestation, whether you have inflammation of the eyes, whether you have heart disease. That may affect which ones you may choose. But for the most part, the biologic drugs tend to be the most effective things we have. So how do we define inadequate response or persistent disease? So, you know, if you go to your doctor with ankylosing spondylitis, they'll make you do all sorts of measurements. Actually, they've turned out not to be particularly useful in following somebody with disease. What we tend to use is something called the BASDAI, the Bath Ankylosing Spondylitis Disease Activity Index, developed in Bath, England, which has had a long-standing interest in ankylosing spondylitis, including the use of medicinal baths as a way of treating it. And if you've been to Bath, you'll see all the Roman baths from a long time ago. That's where the name comes from. So if you have the same BASDAI over 4, that tends to be the entry point in just about every country to get onto a biologic drug. In Canada, we might say you want to see 2 features of the following 3, a high BASDAI over 4, an elevated acute phase reactant like a sedimentation rate of CRP, and if you don't have X-ray changes, maybe inflammatory changes on the MRI. But the entry point pretty much around the world is a BASDAI over 4. So this is what a BASDAI looks like. It's 6 questions that assesses a number of things such as stiffness, pain, whatever. Each question is scored 0 to 10. You average the 6, and if it comes up over 4, then you're eligible. So if you come to me and you're BASDAI is 4.8, and I put you on an anti-inflammatory drug, and it goes below 4, then I'll say, well, you're responding, and then we don't have to go to the next step. But if it stays above 4 after 2, then I'd say, I think it's time to go on to the next step, and that's to use a biologic drug. Now, some people are tough, and they fill out their BASDAI, and they tend to get a low score, and I think they're just trying to prove that they're tough because they tend to underestimate how much this disease has affected them. And I really see that when they finally agree that it's time to go on to a drug, and they say, boy, I really had minimized my symptoms. I'd managed to cope, I'd managed to deal with them, I didn't think they were that bad, and now I realize just how much of an effect they were having on my life. Okay. So in ankylosing spondylitis, our treatments of choice are the biologic drugs, and they're recommended by SPARC, they're recommended by a group in Europe called EULAR, European League Against Rheumatism. They're recommended by the American College of Rheumatology. They're recommended by a group called RAPID that deals with psoriatic arthritis. Many, the European group, the ASAS group is a European group dealing with ankylosing spondylitis. We all agree that these drugs are the drugs of choice. Currently, they all require parenteral administration, whether intravenously or subcutaneously. And the evidence that they affect disease, I'll show you. The evidence that they do things with work disability and the like, I believe it's there. It's increasingly becoming apparent with the newer studies, but the older studies didn't really consider them. So what we like to say is the absence of evidence isn't evidence of absence. They just weren't part of the outcome measures of many of the studies done in the year 2005 to 2010. Okay. So this is what the drugs look like. There have been no head-to-head comparisons. So this is really looking at the results of these drugs, all the various drugs. And the outcome measure used in many studies is something called the ASAS-20, which is a 20% improvement in 4 measures. Okay? Now you might say 20% isn't a lot, but 20% is good at showing the benefit of a drug versus placebo. Okay, so it is a regulatory hurdle. You may want a bigger response like an ASAS-40 or an ASAS-70, and people do achieve them. This is a regulatory hurdle, but these are the outcome measures that have been validated as being able to show a difference between a drug and a placebo. Okay? So you can see the ASAS-20 responses with the various drugs, adalimumab, which is made by AbbVie, etanercept made by Amgen, golimumab, which is, and infliximab, I think, by Shearing these days. These were the studies, and it shows you that at least 60%, roughly 60% of people had the ASAS-20 response versus 20 to 30% of patients assigned to placebo. These were statistically significant and were the basis for Health Canada and all the other regulatory agencies saying these drugs are to be licensed. The 3 on the right are the more recent ones. Certolizumab or Cimzia is a TNF inhibitor. The ones on the left are all inhibitors of TNF, which is a chemical that drives inflammation. The last 2 that you see are secukinumab. It's called Cosentyx. It's just been approved, and it is not a TNF inhibitor. It is an inhibitor of another chemical called interleukin-17. Okay? So this is the first drug of a different family to be introduced, just introduced this year in Canada, approved by Health Canada. It's covered by the province. Secukinumab is covered for psoriatic arthritis and for ankylosing spondylitis. In fact, all of them are covered for psoriatic arthritis. They're covered for rheumatoid arthritis, but not secukinumab. The TNF inhibitors are. You can see they all have roughly the same response, about 60% ASAS 20, about 40% ASAS 40, about 40% ASAS 40, about 20% ASAS 70. So good responses, and this has really changed people's life, not just in clinical manifestations, but in X-ray progression. These drugs also can inhibit the X-ray progressions I've shown you. So keep you straight. keep you painless, keep you not stiff. You wake up in the morning, you feel like a regular human being. How do we monitor if you don't respond? In other words, if your BASDAI of over 4 doesn't come down with your first drug, then you can switch to another. Before we would switch to another TNF inhibitor. Today you now have the option of switching to an IL-17 inhibitor. The family may be effective there as well. Okay. So we look for a fall in that. We'd like to see a fall in the acute phase reactants. We like to see a decrease in X-rays, which we believe we're seeing. So we're preventing progression. We are changing the nature of the disease. We're changing the landscape of the disease. Okay, so just a few words on extra-articular manifestations, as I'm getting near the end of my time. The bottom 3 were things that I used to see in 1975. Okay? Ankylosing spondylitis, many of our diseases would cause inflammation of the root of the aorta and cause a dilatation of the aorta and dysfunction of the aortic valve. So many of our patients used to get prosthetic valves to deal with that. We would see people with changes in the upper parts of their lungs that looked a bit like tuberculosis. I haven't seen that in years. And even worse, rarely we would see kidney failure because chronic inflammation in some people will lead to the accumulation of a certain protein in the kidneys and other organs and lead to kidney failure. Haven't seen that in 25 years. The ones that we do see, the most common ones are eye disease, uveitis, and enthesitis. Okay, so this is what uveitis would look like, red eye, painful eye. Occurs quite often in people with seronegative disease like ankylosing spondylitis, less than psoriatic arthritis. But it is one of the side effects or it's one of the complications that we see. It is associated with the B27 gene as well. And people with uveitis without Ankspond have a high rate of the B27 gene. So the gene also is a risk factor for developing of uveitis. 20 to 40% of people will have it. Sudden attacks, and it is associated with the B27 gene. So this shows you that the use of TNF inhibitors are capable of reducing the frequency of attacks and are useful as well as in controlling this. And there have been studies published, particularly one just came out with adalimumab in people with uveitis not associated with Ankspond, where it's been effective also in controlling uveitis. So this is now another indication that my ophthalmology colleagues will go to the Ontario government for permission to use the drug, or to your insurance company for permission to use these drugs. Enthesitis, I said, this is where cartilage tendons come into bone. They get inflamed, they're painful, and the most common one is Achilles tendonitis. Those of you who have psoriatic disease or ankylosing spondylitis often might have inflammation of the Achilles tendon, they might have a plantar fasciitis, and they ache in many other places. So these are the various enthesitic points. When this first started off, there were over 50, which is far too many to count. And the ones that the Toronto group, and Toronto has a lot of patients with psoriatic arthritis, the ones they find the most useful are your tennis elbow, your Achilles tendonitis, and your plantar fasciitis. They're the ones they count and use and keep track of in their patients with these diseases. All the others you can include or not, but you get the best and most consistent agreement among doctors on the 3 that I mentioned. And that's clinically, Dr. Aydin is using ultrasound, and she may have additional information. So we've talked about axial spondylitis. We've talked about non-radiographic, and now to bring in the concept of what's called SPA, or seronegative spondyloarthritis. These are a series of diseases that are closely associated, that are similar. And they share multiple clinical features, including sacroiliitis, spondylitis, the enthesitis I showed you, the uveitis, But the ones I haven't talked much about are peripheral arthritis, large joints, knees, ankles, wrists, elbows, shoulders, the association with psoriasis and psoriatic arthritis, which can also cause spondylitis, and the association with inflammatory bowel disease, with Crohn's disease. These are a series of diseases that have clinical features in common and have an association with the B27 gene in common. So in ankylosing spondylitis, the HLA27 gene is present in 80 to 90%. In Reiter syndrome or reactive arthritis following various infections, it's the same, 80 to 90%. In psoriatic disease, you can have spondylitis, but the frequency of the gene is less, 35%. Inflammatory bowel disease in a bit lower than that, but you can still have spondylitis, you can still have peripheral arthritis, still have uveitis, you may have skin disease, you may have bowel disease. A group of diseases that share these features. So they share the genetics, they share the clinical manifestations. I haven't gone into pathogenesis, it's quite complex, and they share the same treatments. So this sort of shows it. Now, if you are working with Spond, you put it in the middle. If you're working with psoriatic arthritis, you'll put that in the middle. If you're a gastroenterologist and work with inflammatory bowel disease, you'll put that one in the middle. So what's important is how we approach disease. And when we see somebody who we think has ankylosing spondylitis, the Wait Time Alliance in Canada, which includes rheumatologists and other specialists, believe that someone should be seen from within 3 months of onset of symptoms. Okay? 3 months. We are trying to achieve this. It's not readily achievable. You've got to see your family doctor who has to recognize this. He's got to get you referred to a rheumatologist, and depending on the number of rheumatologists in your community, that 3-month wait time may or may not be met. Okay? If you have peripheral disease, swollen joints, you should be seen within 6 weeks. Okay? Same thing that I said, seeing family doctor, seeing somebody, recognizing swollen joints, getting you to a rheumatologist. We think those are important time points, and the assessment, either with X-rays or MRI, should also be quick. Ottawa has the longest wait times for MRI in Canada. It's getting somewhere up to 6 to 8 months on occasion, so we sometimes wait a long, long time to get the data we need in order to do the things we'd like to do. Okay, so true or false, you guys have listened to me, okay, and you can answer it to yourself or somebody wants to be spokesman. The absence of the B27 antigen rules out the possibility of a spondyloarthropathy. False, correct. Good. From the onset of symptoms, the average time before ankylosing spondylitis is diagnosed? Yeah, long time. Anti-inflammatories modify the course of spondyloarthritis? They do, but there is a risk, okay, and there's the rub. So anti-inflammatories are associated with bleeding, they're associated with high blood pressure, they're associated with increased rate of heart attacks, they're associated with kidney changes. 20-year-old guy can handle them for a few years, 40-year-old guy maybe for a few years. 55, 60-year-old people start to get into the risk, yet we have to use them in order to get access to other kind of medications. Okay. So which of these is true? Patient can have SPA with no X-ray changes. All patients present with an inflammatory low back pain picture. All our traditional drugs, disease-modifying drugs, can treat spinal disease. And there is no role for biologics, especially at the onset of the disease. Yeah, someone said the first one, and that's the one that's true. Okay? So this is, again, where we really have got to get payers. The European Regulatory Agency recognized the concept of non-radiographic ankylosing spondylitis several years ago. I think the FDA and Health Canada are only coming around now to agreeing that this is a valid construct, that people can have this disease in the absence of hard X-ray changes. Okay, good. So you've been a good audience. Everybody stayed awake. And I'm done.
Would be great. That'd be nice. It's fine. I don't mind. So, okay. This is what, so I'll use the same way. Thank you very much. Thank you very much for coming here in the first place, because when I was first called to give this talk, I wasn't expecting to see this many people. I'm really happy to see all of you here, because I'll say the last words at the beginning. The education of patients are extremely important, and I believe if we keep on doing this, if we train more and more people, I'm pretty sure that we'll be able to get better patient outcomes in the end. So I'm really very happy to see all of you here. So here are my disclosures. None of them are relevant for the talk. So during the talk today, I'll try to cover what is psoriatic arthritis, how it presents, and why does it happen in the first place, what do we do to diagnose the disease, what do we target for you, and what are our treatment options currently, and how can you help, how can you be involved in this process. So psoriasis is a really common skin disease. It affects about 2 to 3% of otherwise healthy population, and up to 1/3 of patients develop arthritis at some point. So this to me is a very important sign, because in rheumatology, there is not one even marker that tells us that if you have the test positive, you'll have 30% of risk for developing arthritis in future. And for this one, you don't even need to take out a blood sample. You just see the skin lesions. Is that a good clue? Despite that, we're not able to use that clue well enough, because patients really still get the diagnosis at a very late stage, and they lose a lot of time. And there are lots of reasons for that. We'll be coming to that shortly. And what we mean by psoriatic arthritis is the inflammatory arthritis which affects the joints, the tendons, and the tendon insertions, the enthesis, and the spine. So pain is not necessarily inflammatory arthritis. Even if you may have some pain, it may be due to other reasons other than inflammatory arthritis. What we mean by inflammatory arthritis is the inflammation within these structures. And just by looking at the numbers, you can come up with a number as 300,000 Canadians live with PsA, but about half of them do have the diagnosis, most probably, and the other half still don't know that they have the diagnosis. And unfortunately, it can occur at a very early age, such as toddlers, or you can have a patient who just started having the disease at the age of 70, but it's much more common at the age of around the age of 30 or 40. Unlike ankylosing spondylitis, men and women seem to be equally affected by the disease. However, if you go and check the subtypes of the disease, if somebody has a spine disease, then there's a high chance that that patient will be a male. But on the other hand, if the small hand joints are affected, it's probably going to be a female. So the gender distribution may vary according to the subtypes, but in general, both genders are equally affected. So how does it present? As I said, in most patients, about up to 80% of patients Skin manifestations are the main manifestations. So they usually go to the dermatologist, they already get a treatment, either topical or systemic, and then they start complaining about the joint symptoms. And the dermatology settings usually have quite good questionnaires to be able to pick up those patients, which studies show that they're really successful, but in real life that doesn't work because we know that the dermatology clinics are also very busy clinics, and they already spend their time on trying to understand their own disease, and they don't have a lot of time to question the joint pain. So it may be also your responsibility, not responsibility, but it may really help you to recognize that pain can be related to inflammatory arthritis, especially if you have psoriasis, and warn the dermatologist or your GP saying that I may have some sort of inflammatory arthritis, I have a higher risk of having inflammatory arthritis. And in about 10 to 20% of patients, they may initially present with the joint pain, and initially they may not have any skin findings, and eventually you may see some skin changes. We know that's quite common in patients that have genetically predisposition. So if you have a family member who has psoriasis or psoriatic arthritis, and you might have the joint symptoms, and despite you don't have any skin findings, you may still get the diagnosis of psoriatic arthritis, mainly on the basis of you may have skin disease in the future. And for a small portion of patients, it may happen at the same time. So what do we do see clinically? Of course, we do see the skin changes. So it's not so clear, but we can see the white plaques over the extensor surfaces of the joints mostly. So there are various forms of psoriasis, but this is the most common version of the psoriasis. And these plaques can be quite extensive. But there is no relationship between the skin severity and the joint severity. In other words, you may have a very mild psoriasis, you may not even complain about that, so you may not see a dermatologist in your life ever, but when you come to the rheumatology clinic, when you question about psoriasis, you may say, oh, I do have some lesions in my scalp, but that doesn't bother me at all, but you may have 20 swollen or tender joints in your visit, so it doesn't have to correlate with each other. And one other clue that we take very seriously is the nail findings. Those may be really well hidden because for some of the patients, the skin psoriasis may not be visible from outside. But if you have a close look at the nails, I'm not sure if it's clear enough, but you can see that there may be small pittings on the nails, or the nail can be separated from the nail bed. And that can easily be misdiagnosed as a fungal disease. So there have been quite a high number of patients that I referred to dermatology on the basis of the clinical features from the joint perspective sound like psoriatic arthritis, so do you mind checking for the nail changes? And the patient comes back saying that I have psoriasis, I don't have any skin disease, but the nail changes are nail psoriasis. So that's a clue, and that's an important clue because we know that if somebody has a nail disease, then the risk of developing arthritis in the future is much higher compared to somebody that doesn't have a nail disease. And a very simple recognition, but by recognizing this, we had a better understanding of the pathogenesis of the disease too. So small observations make a huge change in understanding the disease. So how about the joints? This is one of the reasons why I really wanted to get involved in the field of psoriatic arthritis from the beginning. It can mimic everything. It's such a complicated disease, and I'm against the mislabeling psoriatic arthritis as just having one type of disease. I believe we're talking about for different type of diseases, and as a researcher, we have to focus on different subtypes differently so that we'll be able to clarify things much better. When I say different subtypes, here you can see which joints can be affected during the process. You can have the spine disease, and I really enjoyed being the second speaker so that I don't need to cover the spine disease. It's basically identical to ankylosing spondylitis. But other than that, you can have the small joints of the hands, which is usually the symmetrical polyarthritis type. So it can mimic rheumatoid arthritis. Any patient with psoriatic arthritis and rheumatoid arthritis can be identical other than the skin manifestations. Or you can have asymmetrical oligoarthritis, and that means the patient may have one or two knee or ankle joints swollen, not anything in the hands, anything on the spine. So it's just a little bit, one or two joints, which can still be bothering because they can't walk. Some of the patients present with, I have some pictures about that, the small joints that are close to your fingertips can be affected, so that can be the only manifestation, and that can mimic osteoarthritis. So there are quite a lot of patients that have the misdiagnosis of osteoarthritis, but if you have a closer look, they actually have psoriatic arthritis with this subtype. And they can have spine disease, and there's a destructive form of arthritis, thankfully, which is really very rare. So this is one example, for example. You can see that, I hope you can see that the knuckles have been swollen, the joints have been swollen, and we started seeing the deformities in the joints too. Whereas this subtype is different. This patient didn't have anything else in any other joints. It was only these joints that were affected. So if you do more imaging, you recognize that these are not the same patients. So these patients have to be approached differently. So everything starts with inflammation inside the joints, meaning there is the synovial tissue, the inflammatory tissue surrounding the joint. And when that's inflamed, it starts producing inflammation and effusion fluid inside the joint space. So that's why the joint becomes more swollen. And when the joint capsule is extended by fluid, it's more painful. And that's a period where we can do something. When there's inflammation, we have medications that really work well. But as the progress keeps on going, as it progresses, we start seeing the cartilage damage. And eventually we start seeing bone erosions. Not for all patients, but that's a risk. And these pictures were from the same patient's right and left sides. So this is how we should be seeing the joint space. In between the two bones, there's a space. Here you can see that the bone space is not there anymore. So there is severe destruction on this side. And so this is damage, and damage cannot be taken back. So that's why we should be targeting for inflammation before the damage occurs. One other thing that we see in psoriatic arthritis, quite unique to psoriatic arthritis, in the other diseases we see that less common, is a swollen digit. So it's not just the joints. So in this patient, for example, most probably I need to do the imaging, but these joints should have been affected by the disease. But at the same time, the tendons on top of the digit or on top of the finger, as well as the bottom of the finger, they're also inflamed as well. So the swelling is coming from different structures being involved in the same process. So that's psoriatic arthritis. It's not just the joints that are affected during the process, it's all the joint area that is affected. So this is seen in about 30 to 40% of patients, and it's a different manifestation. So if you don't put it in a clinical trial where you test the efficacy of a medication, you may not be able to understand if the patient will be responding to this manifestation. And this slide has already been shown by Dr. Karsh. Enthesitis, the tendon insertion site can be inflamed in this disease, and it can really give a lot of pain to the patient. We have enthesis everywhere in our body. Very good screening questionnaire is the heel pain. The Achilles tendon insertion is quite frequently inflamed. It's about 20 to 40% of patients have clinical features of enthesitis, but actually if you do imaging like ultrasound, you see that it's actually much more common than that. Of course, uveitis, as mentioned by Dr. Karsh, is a frequent finding in psoriatic arthritis too. It's not the only manifestation, so we can also see conjunctivitis, which is a milder version, and the uveitis is seen in only 7% of patients. So that's a less concern, but still a concern in psoriatic arthritis. So patients may have a red eye, a pain in the eye, light sensitivity, and a blurry vision. So they usually don't think that this can be connected to this arthritis, so they don't even think about mentioning about that to us or to the dermatologist, but this is something that we should be digging in each visit you come to see us. And the bowel disease, unfortunately, these patients have approximately 7 to 9% times higher risk for developing inflammatory bowel disease. Again, this is not something they bring up as an issue, but they may have ongoing abdominal cramps, diarrhea, and bloody stool. This doesn't necessarily mean that they will have inflammatory bowel disease, but if they have it, we usually send the patient to a gastroenterologist to get their opinion because they are the ones to rule that out. And something we don't always have a chance to consider, but these are really, really important because we know that we're not talking about diseases that are limited to the joints. We're talking about systemic diseases, and systemic diseases come with other features too. like these patients have high uric acid levels usually, and gout is much more frequent in these patients. So somebody with psoriatic arthritis can have joint manifestations which seem to be well suppressed with the current medications, and all of a sudden you start seeing other type of joint manifestations. So that can be gout on top of it. And these patients have high risk of developing cardiovascular disease, and I'll be talking more about the obesity. They are depressed more frequently than the other people. They do have more fatty liver, and the risk of malignancy is slightly increased too. So why does it happen? We don't have one particular reason for that, but with each evidence we know a little bit more about it. And the genetics is a very important aspect of it. We know that if there is a family member in your first-degree relatives that has either psoriasis or psoriatic arthritis, then you have a high risk of developing psoriatic arthritis. And as I was mentioning, even you don't need to have psoriasis because that's important to be really significant in the family history. And unfortunately, it's not like ankylosing spondylitis that we can identify one particular gene that is responsible. We have multiple genes in psoriatic arthritis, and some of the genes are different in skin disease, and some of the genes are different in joint disease. For example, HLA-CW6 seems to be more important in the skin assessment, in the skin involvement, whereas it doesn't have a major role in the joint. So we don't know what that really fits in, but in the future we'll be able to understand more. Genetics is really important, not at this point to be able to understand which patient will have the disease. We don't use it for diagnosis, or we don't use it for predicting patients. But once we identify certain genes, we go to the mechanism of action, mechanism that is triggered by that gene. And that mechanism gives us new options for new treatments as a research. So that's a very important aspect as well. And the other aspect is the environmental factors. We know that infections are really important. But by definition, psoriatic arthritis is not an infectious disease. So when you take a sample from your joint, for example, it doesn't include any microbes at that point, so you wouldn't get any benefit from an antibiotic treatment. However, we know that there's quite good evidence on past infections with certain microbes may trigger the immune system to react against your own joint. So the history of certain infections may increase the risk, but we don't know why that's happening. And I just came from an international meeting on the field of spondyloarthritis, and I was amazed with the fact that the gut flora has an increased topic, is a hot topic in the area. So between 6 sessions, 1 session was only separated to the gut flora and how that modulates the immune system, and I'm pretty sure that in the future we'll be talking more about that. So we know that patients have more inflammation in the bowel, but at the same time, the inflammation in the bowel has a potential to trigger all the disease activity. Another important aspect why the disease can be triggered is the trauma and biomechanical factors. And this was already well known in the field of psoriasis, because I already shown you this picture. It's not a surprise that patients have more lesions at the elbows, at the knees, or at pressure sites, because when you apply pressure to a certain site on your skin, then you have a high risk of developing psoriatic lesions at that site. And that's called the Koebner phenomenon. And that's also true for example, if you have a cut, if you have a bruise, if you have a tattoo, then having a risk, having skin lesions at that site is more prominent. And that was also shown for arthritis too. So the emphasis are exposed to biomechanical stress throughout life. And it doesn't have to be a major trauma. So whenever you walk, whenever you step on your foot, you apply biomechanical force on the tendon again and again. So each time is another stress. So that has been shown to, of course, it's very hard to do that type of experiment in people, but there have been quite a few good designed animal studies showing that if you avoid the movement of the limb, you don't have arthritis. But as soon as you allow the extremity to move, then you start having arthritis in those models. So we know that it's really important. And that gives a link to obesity too. We well know that patients with psoriatic arthritis have a higher body mass index. They're more overweighted than patients who have psoriasis but not arthritis. But this can be understandable because if you have arthritis, possibly affecting the knee, for example, then you could be exercising less. It would be more difficult to stay fit. So it may be understandable why you have more weight. And of course, there is emotional consequences of having arthritis that might have included the obesity, influenced the obesity too. But there had been another study which includes more than thousands of patients. I really like this study because they did a cross-sectional analysis first, trying to understand how many patients have psoriasis only and how many patients have arthritis on top of it. And then they went back to the medical records of those patients when they were 18 years old and when they didn't have either psoriasis or arthritis. And they saw that patients who were more overweighted at baseline had a high risk of developing arthritis in the future. So this shows that the obesity may be a triggering factor for developing arthritis in the future, and it all comes to the biomechanical forces applied to the joints and the antithesis. So we don't know which one triggers the other one exactly, but it seems to be like a vicious circle, and regardless of where we are, if we're able to stop this vicious circle, patients do get benefit out of it. And the last environmental factor that I want to talk about is the smoking. As Dr. Karsh mentioned, it's really well known in the field of psoriatic arthritis too. If you smoke, there's a higher risk of developing inflammatory arthritis. And we've done a study about that too. If you smoke, which type of psoriatic arthritis that you'll have may be identified too. Patients who smoke have more spine disease, for example, like ankylosing spondylitis. And if you smoke, as Dr. Karsh mentioned, the response to medications is less compared to patients who do not smoke. So it's always a good idea to stop smoking. So what do we do when we see you in the first place to give you the diagnosis? We have to collect all type of information that we can collect. If we're talking about the peripheral joints, it's usually easier, but especially when we're talking about the spine that is not visible from outside easily, it's a little bit more difficult. So we start by talking to you, we continue by examining you. I tend to do a lot of imaging. As I mentioned, it's my main interest area. I combine different imaging modalities to get the maximum information. The X-rays, for example, they don't give any information about inflammation. They only give information about the damage. So when I see you for the first time, I tend to ask for the X-rays, trying to see how many erosions, how many bone destructions you have. That's the baseline assessment, because if there are baseline destructions, that's the negative prognostic factor for future, and that tells me that we shall be treating you more aggressively. We shall be giving you stronger medications in terms of to suppress the inflammation. To be able to understand if you have active inflammation or not, we have to use the other imaging modalities like ultrasound, and I have an example about that. By using ultrasound, it's a very patient-friendly modality. In a couple of minutes, we're able to understand if you have any inflammation inside the joints. Unfortunately, ultrasound only helps for the peripheral joints and for the antithesis. It doesn't help for the spine. So for the spine, more than the X-rays, we need the MRI. For peripheral joints, the MRI is less and less used, and it's not very common. Of course, we need to do the blood tests. Unfortunately, these diseases are seronegative diseases. That means we don't have a marker in the blood that are helpful for diagnosis. We still need to do them to exclude other diagnoses, and at the same time trying to see how much inflammation you have in your blood. So basically, all of the things that we're trying to do is we have a blurry vision, and we collect as much as information to give you the chance of getting the best treatment that you can. And this is what I was mentioning to you about using an ultrasound. We have the current technology brings us a very high resolution machine, which gives you, so this is a bone, this is a bone, this is your joint space, and this is the joint capsule that I was mentioning. So the orange signals that you see here is the active vessels inside the joint space, which shows the active inflammation. So this might be ongoing even if you don't have any pain anymore. So you may have the diagnosis already, you may be on treatment, you may be doing well clinically, but when we have a look at the joints, these may be the changes that we see. And even more important than that, I want to show you something. Do you see the small hole in here? It's the bone damage. And there is still a vessel inside the bone damage, which shows me that there is one signal vessel trying to dig the joint. So there are a lot of information that we can collect from the small joints, basically. So once we have the diagnosis, we use all the tools to give you the diagnosis of psoriatic arthritis, and then we have to make a decision about how to move ahead. We target for remission, and that means we want you to wake up in a very healthy way, forget about your disease, start your day immediately, no pain, no stiffness. Just try to remember your medications because that's the only way to keep that going. But we cannot achieve that for all patients, unfortunately. We do have very strong medications, and well, I believe that if we were able to combine all mechanisms of actions, we would be able to suppress the inflammation in the majority of patients, but then side effects would be a major concern. So we always have to find a balance between the disease activity and the side effects of the medications. And of course, there are two important components of the treatment, the pharmacological and non-pharmacological. The second part will be highly covered in the next talk, so I'll focus on the pharmacological part. And at this point, I would like to put another emphasis, as this was already mentioned by Dr. Karsh, but disease-modifying antirheumatic drugs, because this is the definition that we commonly use in our nomenclature. So these are the drugs that slow down disease progression. So these are not painkillers. They don't work on the day you take them. It takes some time for them to work. They reduce the pain, but not by fighting with pain. They reduce the inflammation, and at the end, by reducing the inflammation, they reduce the pain. In other words, they wouldn't do anything if you take them for your headache, but it works if you take them for your arthritis. The list of medications that we use in this field are actually longer, but these are the commonly used medications. I tried to just shorten the list a little bit. And I just want to mention that not all medications are the same. You may get a prescription about some of those in your treatment. The first one is, for example, the non-steroidal anti-inflammatory drugs are about pain management. So they don't help you for the next day or for the other day for your psoriatic arthritis. We're talking about the small joints. For your small joints, you need something different. And corticosteroids, we use those medications very commonly in the other fields like rheumatoid arthritis, for example. And for the peripheral joints, for the small joints, they also would work very well in psoriatic arthritis. But unfortunately, as soon as you stop the prednisone, there is a risk of developing a flare in the skin manifestation. So that's why it's almost never a first choice for our medications. But I personally very much like using the intra-articular steroids, meaning there are not many systemic side effects of the medication. If you're talking about just one or two joints that are significantly persistently inflamed, you can put the medication just inside the joint space. Moving a little bit, medications like methotrexate, sulfasalazine, or leflunomide have more role in psoriatic arthritis. So these are called as conventional DMARDs, and I'll be giving a little bit more information about that. The next three are called as biological DMARDs. I'm sure you hear more and more about these medications, as also covered by Dr. Karsh a while ago. So TNF inhibitors, IL-17 and 12/23 inhibitors. And we have the new group of medications that are oral medications. So just comparing the two, the conventional DMARDs and biological DMARDs are different group of medications, so they do not belong to the same family. Conventional DMARDs have been available in the market for so many years. I don't know, I think methotrexate can be even more than 50 years, I guess. So the delivery method is usually different. Of course, there are exceptions, but for the conventional DMARDs, it's usually pills, and biological DMARDs is usually self-injections. There's one with infusion as well. The drug target for conventional DMARDs like methotrexate, sulfasalazine, and leflunomide are less specific, meaning they target for different type of cells at the same time. The biological DMARDs target for certain specific targets. And the response time, the conventional DMARDs, you'll need to be a little bit more patient. It may take about 6 weeks to 3 months to see the full efficacy. Whereas for biological DMARDs, it's usually quicker. It takes about days to weeks to see the response. The side effects, it depends on the target. So if the target is less specific, if you target for several cells at the same time, then you have to face more side effects like liver damage, bone marrow suppression, or miscarriage or birth defects can occur with conventional DMARDs. Whereas with biological DMARDs, these are less concerned. However, when they target a molecule, they're really effective. They strongly suppress it. So we may be concerned about some other side effects, like they have a high risk of opportunistic infections, which we really need to cover our patients very well. And there may be some skin reactions where the injection takes place. They're usually easy to handle. And there may be an increased risk of malignancies, especially the skin cancer, although the recent literature is more suggestive of the disease itself, not the medications to increase the risk. The cost is extremely different. The conventional DMARDs have a much less cost compared to the biological DMARDs. So for all of these reasons, there is a stepwise approach for treating our patients. We cannot just decide on which medication to go. We have regulations. We don't need to go box by box, but this is just to give you an idea. This is an international group of people that works in the field of psoriasis and psoriatic arthritis. So we come all together a couple of times a year as dermatologists and rheumatologists, discuss patients and all the outcomes from our own perspective, discuss the new data, and come up with some new conclusions and ideas. So this table shows you that we cannot just pick up any medication we want. We have to focus on the data. If somebody has peripheral arthritis, that's a different type of medication treatment needed. If it's axial disease, it's like ankylosing spondylitis, basically. Enthesitis, dactylitis, skin and nail need different approaches. So we have a patient, and we start thinking about it. So we're at the level of, we don't have any question marks about the diagnosis anymore. So we think about which pattern am I trying to deal with? Am I just talking about the symmetrical polyarthritis which affects the small joints? Or does the patient have spine disease at the same time? Because the medication that I'm choosing for the small joints may not be effective for the spine, and patients may be telling that, okay, I'm better with my hands, but I still cannot wake up because of I still have morning stiffness because of the back pain. So we have to understand what the patient really has. And then, of course, we need to identify the activity of psoriatic arthritis. A patient that has 2 joints of the hands is not the same as the patient that has 20 joints of the hands. So depending on the disease activity, how much severe inflammation there is, and how that affects the patient's life, we may need to choose different medications. And also that's true for the x-rays that I was mentioning. If somebody has erosions like bone damage from the beginning, that's different compared to a patient that has been having the disease for 20 years, and after 20 years you get the x-rays, you still don't see any bone damage. That pretty much convinces me that the patient will never have bone damage in future. And unlike the other diseases that we take into account, the activity of psoriasis and the nail are also very important, because we do have very good medications that are able to cover both aspects of the disease. So if you want to treat the disease well enough, we need to make sure that we're able to cover all aspects of the disease. Of course, previous medications are really important. If somebody has failed one type of medication in the past, there is no need to push on that medication and again. So that's something that needs to be taken into account. Comorbidities are really important too. Somebody who is 70 years old with some kidney function abnormalities is not the same patient who is 20 years old and otherwise completely healthy. So all the other comorbidities need to take into account when we're prescribing something. Of course, personal factors are really important. Again, I'll give you some examples. If we have a patient that is 25 years old who is planning to get married and planning to have babies in future, then the medication needs to be safe for the pregnancy, because you don't want to you don't want to change the treatment in 3 months again and again. Those type of changes are really important. And once we clarify which medications are potentially going to be helpful for our patient, then we discuss those medication options with our patients. Your preference is always very important to the final conclusion. So I'll skip this one. It's already covered by Dr. Karsh. It's basically the same for spine disease. Thankfully, for other joints, we have other options other than the spine. The conventional DMARDs that I was mentioning, the methotrexate, sulfacetamide, and leflunomide, are effective for the peripheral joints. So that's why we always use these ones before the biologics. We know that clinically it works, and also from the regulatory aspect, this is mandatory to use these medications. So we can either use them as a monotherapy or as a combination therapy. These ones can be used as combinations. These cannot be combined with each other. To give you some examples, as I said, most of them are oral. If you're talking about the conventional DMARDs, sometimes with methotrexate there's an injection form. The frequency depends on which medication we're talking about. To be able to see the response, we never stop the medication before 3 months unless we're talking about a side effect. So if I see a patient in 6 weeks saying that didn't get a good response yet, I would say still we need to hold on a little bit more before we exclude the medication from the list. As I said, we can use it as a combination. But with these medications, we need to be careful about the side effects. As I was saying, these are not specific to one certain type of cell. Then we need to do regular blood monitoring. On the other hand, biological DMARDs are strong immunosuppressors. They're quicker in terms of the action. Still, we need to wait for 3 months to be able to fully assess the response, because we know that there's an increasing trend in the response. So usually what happens in a couple of weeks, patients say that I'm better, but I'm not good enough. But if you wait for 3 months, you are able to see the full response. That's why we have to hold until the 3 months. And because of the high cost and because of the high opportunistic infection risks, for the spine is different. For the peripheral joint, it's never the first line. And one of the major issues about those biologics is the risk of tuberculosis. So before the recognition of increased risk of tuberculosis, we had some literature on increased risk for that, but then we found out that it's important to identify patients who do have a high risk. That's why we do have a good screening program. We do skin tests prior to the medications, we do chest x-rays, and then if there's an increased risk, we give the medications to treat the latent tuberculosis prior to the biologic, and that significantly decreased the risk of having tuberculosis. And these are examples for the biological DMARDs. As you can see, one of them is an infusion, the rest are injections, and the frequency is highly variable depending on the medication. It's from every week to every 3 months, and there is a loading dose for some of them. So coming back to the education, your contribution is significantly important for understanding the disease, because as I was showing you at the beginning, it's a very blurry vision. You come with pain, and we have to dig everything in order to understand if you have inflammatory arthritis or not. So it's really important for you to understand what to expect from the disease, what are the features of the disease, so you can recognize yourself and you can let us know if you have it or not. And you already saw that there are the comorbidities of the disease that you should be taking care of. Like there's increased risk of diabetes. You can live a healthier life in terms of your diet. You can try losing weight. So these type of things will help you to have a healthier life in terms of your arthritis as well. It's very important to be educated on the side effects of the medications because there is no way to predict who's going to have the side effect. But at least we can take all the precautions to avoid them. And if you have the side effect, please get in touch with us so we can do whatever is needed to treat you. And I know that it's not always to keep on doing your exercises, and this is going to be covered. Keep on doing your exercises. It's a very important part of the treatment. Even though you feel good, we still want to keep seeing you on a regular basis. This is for understanding. I showed you the picture of the ultrasound picture. You may be feeling perfectly fine, but the disease activity may still be there. And this is something that we can find out only by seeing you. And of course, also for the side effects of the medications, there may be some things that you're not able to realize, and we may be able to understand by doing a screening or doing the physical exam. So we have to see you on a regular basis. And a few words about research. Thankfully, thousands of researchers are trying to find out what's going on in the field of psoriatic arthritis. It's not limited to this area, but we really need to work a lot on this one. Why does it occur? As I said, those patients do go to the dermatology clinics all the time. We can find that out. We can shorten the referral times to see those patients earlier, to treat them as soon as possible before the damage occurs. Unfortunately, we're not there yet. So is it possible to diagnose those patients earlier? Is it possible to identify patients who do have a high risk of having progression in future? So if I see the patient with lots of bone damage at baseline, I already have an idea. But the main idea is to see the patient who doesn't have anything at baseline, just have the disease for a couple of months, and then trying to understand, is this patient going to progress, so that I can give a different management to that patient. And you notice that every patient is different, but we don't know which medication is going to be perfect for that patient. So if we can find out the differences among people, different patients, we may be able to give the perfect treatment from the beginning and avoid the risk of failing to treatments. And another important aspect is that what we notice and what we believe is important may not be exactly the same with what you believe is important. And I'll give you an example about that. There is another group of rheumatologists called as the OMERACT group. It's an international organization again. So that group works on identifying which outcome measures need to be put on clinical trials, trying to understand if that medication works or not. So initially, the group only consisted rheumatologists or other physicians, as well as some statisticians. And then we came up with some outcome measures to be used in clinical trials. Then at some point, we realized that patients need to be a part of the understanding of the disease, because you may be feeling different. And surprisingly, it's not limited to psoriatic arthritis. It has various inflammatory conditions. We recognize that regardless of which disease we're talking about, all patients' priority was fatigue. And that was not included in any of the clinical trials. We don't ask for it, because we believe that that's not specific, and we can't treat it. That was our argument. But to be honest, we're not looking for it. So that's why we don't know anything about that. So the patient participation changed our approach to the diseases already. So you can speak up, and let us know what's important for you. And I would like to talk about a registry that I was able to build with one of my colleagues when I was in Turkey. So that's an online database, only included centers from Turkey to start with. Just to give you the numbers, in between September 2 years ago, and so in 2 years, we were able to recruit more than 1,200 patients to the database. So this is a huge number, and it significantly improves our understanding about the disease. In a clinic, if you have like 50 patients with psoriatic arthritis, your understanding will be limited. The next patient that is coming after that, what are going to be the features? So it's going to be limited with your own experience. But if you have the data from more than 1,000 patients, you'll know about the disease much more than that. So this registry, for example, only included whatever we know from you, just collecting that data, nothing additional in addition to our clinical practice, and combine all the information, do the analyze, write the paper, share with all the other physicians in the world. And for example, I'll give you some of the results that we had from the database. The perception of the disease is different in women and men. So we already talked about that the occurrence of the disease is different. Even though you share the same genetic inheritance, the occurrence of the disease is different. And when you have the disease, the feeling is different. So they have the same severity of radiographic damage. Women do feel worse, and we don't know why. And I've been mentioning that the ankylosing spondylitis spine involvement is quite identical to what we see in psoriatic arthritis spine involvement. That's what all studies tell us. There is not, we don't have much data on the spine involvement in psoriatic arthritis and the efficacy of the medications. We all assume that if something works for ankylosing spondylitis, it's going to work for psoriatic arthritis. That may not be true. For example, in this registry, we used the screening questionnaire to understand if the patient has spine disease. They didn't work as they were working in ankylosing spondylitis. So we really need to focus on this disease in particular. We cannot just assume that these are the same. Another interesting point that another medication, hydroxychloroquine, so I wouldn't expect for you to be aware of this medication. It's not really very commonly used in the field of spondyloarthritis. It's not a part of the international recommendations ever, but this registry showed that almost 8% of patients are actually using it. And this is very similar to a UK data. Again, that was a registry. Almost 10% of patients were using this medication. So they use it because the clinician who sees those patients believe that it works. The international recommendations cannot use it because it's not data-driven. So maybe it works, and we don't have the data yet. So we have to provide the data. This is another example how our research pathway needs to be shifted. And in that registry, on 1,000 patients, half of the patients still had active disease by using different outcomes like pain, patient and physician global assessment. So we have very strong medications, we have very effective medications, but we're not doing really good enough. And we don't really know why that is the case. Is it the long waiting lists? Is it we're really too late? Is it the comorbidities? We don't know that. And that really points out to the unmet need in the area. And the same database showed that the comorbidities are really extremely frequent in psoriatic arthritis. So just by controlling the joint disease, it doesn't mean that we're really good physicians. We're able to suppress the real inflammation. We have to look at the big picture and try to suppress all the other comorbidities too. And another important thing was that patients with higher education had less comorbidities. So that means patient education is really important, not only to treat the comorbidities, but also to prevent the comorbidities. So you can help because you know the answers, or even if you don't know the answers, you have the answers. So by sharing your information with us, you can help us to understand what the answers are. So you can tell us and you can share with us. So it all started at the Registry of Turkey, but I'm really grateful to say that now it's Canada, it's UK and US. So it's going to be thousands of patients worldwide at the end because we'll be able to understand when we talk about a patient back in Turkey, are we talking about the same disease features in here? How much the genetic factors play a role? How much the environmental factors play a role? So that's going to give us a better understanding of the disease. And this is, I think, the last slide that I have. So since the time that I started rheumatology, we already had good medications. So I never had it, and not chance, but never practiced before that era. So I'm really grateful to all the researchers that put enormous work on this area to develop understanding the pathogenesis of the disease as well as the treatments. And of course, the patient input, if other patients didn't put their input, it wouldn't be possible to understand, it wouldn't be possible to come to the level that we are at this point. So now it's our turn. Yeah, I would like to acknowledge these people from my university, from the university that I had my research fellowship, and these people that I'm still in collaboration with, and all the organizations that support my research. Thank you very much.
So thank you everybody for listening to that. Another maybe quick round of applause for the two wonderful presentations that we had. Looking at my watch, we'll probably take about 10 minutes and then come back and we'll have a quick presentation by Karen and then myself. So make sure that you write down all your questions. We're going to get Sarah to collect them, and then in about 30 minutes we'll actually start asking the questions. So I encourage you guys to step up, kind of walk around, and then we'll get back to it in about 5-10 minutes. All right, so taking into account that we have about 45 minutes left, I'll invite Karen up to start her presentation. I have the wonderful opportunity to introduce the registered physiotherapist and clinical practice lead working for the Arthritis Society since 2003. And her kind of main efforts is to work with people with arthritis on how to exercise safely. So a big welcome to Karen, and hopefully you'll be able to listen.
Thank you. I always enjoy this topic. It's my favorite topic, is exercise and arthritis. So thank you for inviting me. And the good news is my talk is not quite as detailed or as information loaded as the other two, so it'll be a little easier for us this late evening. All right. As a little bit of a background of the Arthritis Society, if you don't know already, we're Canada's leading supporter of arthritis research, and that's the screen on the left. And we also assist with training healthcare workers in managing arthritis, as well as supporting patients such as yourselves to learn how to manage your arthritis. And my role as a physiotherapist at the Arthritis Society is to help people learn to better manage their arthritis. I just want to give a little plug for our Arthritis Society website. It's simply arthritis.ca, and it can give you a lot of information about arthritis and managing your arthritis. We also have a few online education programs. One is this one about managing fatigue. Another one is about managing chronic pain. And another one is about improving your way of communicating with your doctors. So I just wanted to give a little plug about our website. So on to the topic that I'm going to present is the top 10 reasons to exercise with arthritis. This happens to be a photo of my parent-in-laws in the Netherlands, and they're an excellent example of people who are benefiting from regular exercise on a regular basis, and they both have a little bit of osteoarthritis. So the number one reason that we recommend exercise for all of our patients is strength. The stronger you can make your muscles, the better they'll support your joints. So if you happen to have ankylosing spondylitis, you want to make sure you keep the muscles in your back nice and strong to support your back. And if you happen to have arthritis in your knees, you want to make sure you keep your quadriceps muscles strong. So that's one of the number one reasons we recommend exercise for our patients with arthritis. One of the other reasons is endurance. The stronger you keep your heart and lungs with aerobic exercise, the better you'll be able to stay active and function on a regular basis. The regular Canadian physical activity guidelines for adults is to try to get about 150 minutes of exercise per week, and that means about 30 minutes a day, which doesn't come up to too much, and that's what we try to encourage our patients to do. And we also encourage them to add that strengthening twice a week. Flexibility is another good reason to get exercise on a regular basis. By keeping your muscles more limber and by keeping your joints with good range of motion, it'll improve your ability to function on a daily basis. And some examples of good flexibility exercises are either stretches or things like Tai Chi or yoga that can help with flexibility. Another really good reason to exercise is basically to improve your overall health. We actually, as we heard earlier in the talks, patients with inflammatory arthritis, like ankylosing spondylitis or psoriatic arthritis, have higher cardiovascular risk because of their disease, and it's another reason to continue to add or include exercise on a regular basis. But we know that regular exercise can help with all of these comorbidities that can happen with arthritis. And if you haven't seen Dr. Evans' 23 and a half hours little infomercial about exercise, it's excellent. He's a family physician that works out of St. Michael's, and this little infomercial is all about trying to get 30 minutes of exercise in your regular day and how it can help reduce risks for heart disease, diabetes, osteoporosis, and obesity. Number 5 on my list is better posture. So practicing Tai Chi, practicing yoga, practicing some posture exercises on a regular basis can actually help improve your posture. By strengthening your postural muscles and practicing good posture, it can help improving your posture easier. The other thing that's been shown is people who exercise on a regular basis, especially if they exercise early on in the day, have improved sleep at night. There's some link between regular exercise and improving your drive, your sleep drive for sleeping. These are my two cats. They don't have any trouble sleeping. Bone density. So regular weight-bearing exercise, that means either lifting weights or just walking, can help improve the strength of your bones. And we do know that people with ankylosing spondylitis and any other kind of inflammatory arthritis also have a slightly higher risk for osteoporosis. So regular exercise can help maintain your bone density. And coincidentally, the Osteoporosis Canada guidelines for exercise also happens to be 150 minutes of weight-bearing exercise per week, plus strength training 2 or 3 times a week, as well as balance exercises. So that still tends to be our recommendations. Try to get 30 minutes of exercise a day and try to get some strengthening in and some balance exercises. And Tai Chi, as shown in this picture, I'm not sure if anyone's tried Tai Chi, it's a wonderful form of exercise to help improve your balance. There's other exercises that can help improve your balance, like walking or cross-country skiing or just practicing some balance exercises in yoga can help improve your balance skills. Basically, with a lot of skills like balance and flexibility and strength, if you don't use it, you lose it. So practicing on a regular basis, you can actually improve your balance. I just wanted to mention here in Ottawa, we have an excellent program that's organized by Public Health in combination with the City of Ottawa called Better Strength, Better Balance. Has anyone here taken it? It's a free of charge exercise program twice a week, and it's actually designed for seniors over 65 to practice improving strength and balance. And it's very popular. And if anyone's interested, I do have a phone number for that. Number 9 on my list, it's actually been shown if you combine regular physical exercise and healthy eating, it can be one of the best ways at managing your weight or trying to lose weight. And so that's something we like to keep in mind. And the other thing to know is every time you take a step, 3 or 4 times your body weight goes through your hip and knee joints. So if you actually lose 10 pounds of body weight, you can actually lose 30 pounds of stress on your hip joints and 40 pounds of stress on your knee joints. So don't underestimate how just losing 10 pounds can help reduce the stress on your hips and knee joints. And last but not least, my 10th reason for exercising on a regular basis is fun. If you choose an exercise that you enjoy, it can actually be enjoyable and it can actually improve your mood and help you feel better, even though you have arthritis. The next little bit of my talk, I just wanted to show you there actually is some pretty good evidence that combining exercise and arthritis is a good thing to do. So this is a scientific review study that's shown that indeed, if they take a large group of adults with arthritis and they combine it with 150 minutes of that moderate to vigorous exercise per week, they can help reduce their pain and improve their function, their mood, and their quality of life. So there is evidence out there showing that exercise is good for patients who have arthritis. There's also a very nice review study with a very large group of patients with ankylosing spondylitis that showed that both recreational exercise, so that means things like walking or bicycling or even playing soccer, and back exercises, both those kinds of exercise can help patients with ankylosing spondylitis reduce pain and stiffness. And in that large study, when they asked patients what they preferred Most people actually preferred the home exercise version because it was more time efficient and economical and more convenient. The other thing they showed is that patients who exercise on a regular basis, that meant 2 to 3 times a week, they actually end up doing better than those patients who exercise just once in a while. So that's what we try to encourage our patients. Try to get into a routine and practice your exercise at least 2 times a week. This was another review study that included over 700 people who had AS, and they combined all different kinds of exercise programs and showed that all of the exercise programs helped improve the patient's flexibility and function. And it also showed that exercise in water was the best for reducing pain and improving function. So in general, most of our patients, especially our patients who have pain, prefer exercising in water. So here are some practical tips if you have arthritis and you want to get exercising, is listen to your joints. If you happen to be in a flare, we haven't sort of talked about that tonight. Most people who have arthritis have periods of time when they're feeling better, when their medications are working well, their arthritis is in remission, and that's when they can exercise the best. If you're in a flare-up, it's going to be a little harder to do an exercise and you might have to choose to do something more gentle. So keep listening to your joints. Learn to modify your exercise. For instance, if you happen to be one of those patients who has Achilles tendonitis, Achilles enthesitis, you probably don't want to be running. You probably don't even want to be walking fast. You might want to choose an exercise like bicycling or elliptical or exercise in the water because it'll aggravate your Achilles tendons less. So that's called modification. If you're just starting an exercise program, make sure you start really slowly. That means start with 5 or 10 minutes of your exercise. Don't join an aquafit class if you haven't done anything for years and expect to do the whole hour. Plan to just do maybe 10 or 15 minutes of the class if you haven't done a class before. And then tell the instructor, you know what, I haven't done a class in years. I'm going to leave after 15 minutes because I'm afraid I'll flare up my arthritis. So exercise in the water, whether it's aquafit or swimming, has a lot of benefits for our patients, and it's often one of the first things we recommend. If you happen to have psoriasis, sometimes chlorine is hard on the skin, so you might want to look for a saltwater pool. There are a few saltwater pools in the city, and that might be easier on your psoriasis if you have psoriasis. This is just a slide of some of the pools we have in Ottawa that are run by the City of Ottawa and the different forms of aquafit that's out there. The ones I would recommend in particular are the ones that are called either aquatherapy or chronic pain therapy or the Aqualite. They tend to be better for our patients who have arthritis. If you're lucky enough to have your arthritis in remission, then you probably can do the regular aquafit, and if you're in really good shape, you can do aquaturbo. Some other tips I have about arthritis are avoid exercises that include jumping or repeated twisting. Those are pretty high impact exercise. We regularly recommend low impact instead. So I wouldn't recommend things like a Zumba class can be quite fun, but it's kind of hard on your hips, knees, and feet. Things like tennis are also quite hard on your hips and knees, so I often recommend that's a little harder to start with. So look for lower impact exercise like walking, cycling, elliptical, Tai Chi. And if you are interested, these walking poles are particularly good for reducing the stress on our patients' knees and feet and hips. It does put more stress on the shoulders and upper back, but it can help improve your posture, and it's very good if you have any issues with balance. So a lot of our patients do like these walking poles. So what are some tips for success? Choose the best time of day that will work best for you. By that I mean choose the time of day where you think you're going to have the best energy and where it fits in your schedule. Most of our patients tell us mornings are better, not first thing in the morning because we're stiffer, but before the noon hour tends to be what works best for our patients. If you happen to work full time, I actually really recommend you try to get out in the middle of the day, ask for a prolonged lunch hour, do a bit of exercise then. Try to make it routine, try to do it on a regular basis so it becomes a habit. Pick something that's convenient. Don't join a club that's the other side of the city. Make sure you pick something that's nice and close to home and will be convenient. And think about following the 10% rule that we give all of our athletes. Don't increase by more than about 10% per week. So by that I mean, if you're starting a walking program and the first week you're walking 10 minutes a day, then the next week you shouldn't increase by more than 10%. And 10% of 10 minutes is a whopping 1 minute. So week 1 you'd walk 10 minutes, week 2 you'd walk 11 minutes. Week 3 you'd walk 12 and a half minutes. So really try to increase gradually in order to reduce the risk of injury. Everyone who has arthritis, like ankylosing spondylitis or psoriatic arthritis, has that increased risk of developing things like Achilles tendonitis. So you want to go gradually to prevent that. And my other suggestion is have a plan B for bad weather. I don't expect my patients to be like my Dutch husband and ride their bikes with an umbrella. If the weather's bad, find an option that you can do inside. And I think we live in Ottawa, you better have an indoor option for those really bad winter days. So think of things like there's many places in the city where you can walk indoors. The malls like Billings Bridge have a walking club that the mall is open before the stores are open, and you can come in and safely walk indoors if the weather's bad. For people who don't like to go out and would rather exercise at home, our American cousins at the Arthritis Foundation in the United States, arthritis.org is their website, they actually sell some videos for arthritis, yoga for arthritis and Tai Chi for arthritis, so you can get some videos that are DVDs that you can do at home. The last but not least, I want to talk about joint protection. It's very important if you are exercising to choose the right equipment. Make sure that you are exercising with good footwear, and some insoles can help to prevent symptoms of that plantar fasciitis, that enthesitis that can happen either in your feet or your Achilles tendon. Some of our patients like to exercise with joint support. So if you happen to have arthritis that affects your wrist, you might like to wear a wrist brace when you're on the bicycle and you're putting weight on your hands. You might like one for your thumb to protect your thumb if you're lifting weights. And some of our patients like to wear a knee brace to support their knee when they're walking or exercising. So as a summary, all of our arthritis patients should be encouraged to include aerobic and strengthening exercise training as part of their routine care. And that means, as a gold standard, we're asking our patients to work up to 30 minutes of exercise a day and to try to include strengthening exercises twice a week and try to include some balance exercises as well. So respect your joints, but have fun when you're doing it. Thank you.
Let's have another little quick round of applause for Karen. And an extra big applause for me, because I'm the next speaker. So as this loads, I'm the lucky one who actually gets to talk about my diseases. The title of my kind of presentation is Living Well with Disabilities, and I identified the dis part as lower cases and the ability as like capitals, because I think it's important for us to focus on the abilities that we have and focus on the new normal that we operate with. So if this works, there we go. I have 3 quick objectives for my maybe 10 to 15 minute talk. First one is just introducing the CSA, is what I've already done, why I'm here and who helped us get us here. Another thank you to the sponsors. Living well with these illnesses. For me, illnesses is possible and you're not alone. Just so to encourage that there are support groups and there are people around who have the similar conditions as you. The first question that we like opening with is, how many of us have actually been in a room with other sponders or, AS patients or psoriatic arthritis before? Hands up. And C.S. Lewis has a really lovely quote that says, "Friendship is born at the moment when one person says to another, 'What? You too? I thought I was the only one.'" So here we have a group of friends that now we can start working together. So quickly, again, agenda, background, what is the CSA to me? My road to diagnosis, what I wish I knew then, living with Spondylitis and Crohn's, and kind of talking more broadly about the support community, benefits of kind of volunteer patient advocacy, and the potential whether there's an appetite for an Ottawa spondylitis group. So what is the CSA to me? And this is actually my first opportunity of engaging with the CSA, so it's kind of baptism by fire. For me, it's an opportunity to share, learn, and advocate. So as a young person with both AS and Crohn's, I think it's really important to increase awareness and increase other patients who have similar conditions, because as we see, there's only a few young people in the crowd. It's an opportunity to connect with others, and what we encourage people to do is go to the website. It's www.spondylitis.ca. Join the Facebook, join the Twitter. There's a bunch of support and resources there that you can learn more about Spond and Crohn's in my case. So right now, there's around 1,700 members in CSA, but we obviously want more. And to do that, refer to these types of websites. So who am I? I think this is one of the most difficult questions you can actually respond to, because you don't actually know how to define yourself. So really briefly, I was born in Ottawa, moved away for a while, grew up playing sports, started decreasing my sports activity about 7 or 8 or 9 years ago, and that's when I started getting kind of problems with my back and problems with my bowel system. I'm here because I enjoy getting involved with the community and contributing meaningfully. The one thing I won't say is that I define myself by the conditions that I have. So I'm more than that, and I'm much broader than that. So my personal road to diagnosis started in about 2010, 2012, identifying how young I am, and it started with pains in my lower back that kind of gave a sharp pain down my entire leg and kind of caused me to bend over. In 2015, I decided that it was enough. I ended up getting an X-ray, which led to blood work, which led to a CT scan, which led to a colonoscopy and the diagnosis of Crohn's. And then another 8 months later was actually the MRI, and that was the diagnosis of Spond. The Spond is actually the one that bothers me the most and affects me daily. So waiting that 8 extra months was a bit troublesome. So February 2016 and March 2016 was actually when I was technically diagnosed. And I actually started Remicade 2 weeks ago. And, my second infusion was yesterday, so we'll see how it goes. 4 things that I wish I knew then that now I want to get involved and share with. The first one is, what is Spond and Crohn's? I think actually understanding what it is important to understanding the conditions and how you can actually start to treat it. Who else is out there? That's why getting involved with the CSA is important and why I think everybody should do this. What resources are out there? Same kind of deal. And is it fatal? when you hear ankylosing spondylitis, it's not something that you know of, and I was obviously worried whether I was going to die or something. So the way that I've kind of started to manage living with both these conditions is fourfold. The first is about controlling my diet, and most of that is around anti-inflammatory, and for Crohn's, I'm on a low residue diet. So how I do this with my partner is that, you know, we have an Excel sheet with the ingredients that we can cook with. We have a recipe app, and we try to monitor and control it that way. The next is exercise, and I think Karen kind of explained that. The way that I do it is I focus on low-impact exercises. So Iyengar yoga, there's a great restorative class Saturday mornings. I'm the youngest by about 50 years. I encourage everybody else to join. Swimming and cycling, I think, are really important. Read, kind of educate yourself about your condition and the medications available to you, and ask questions. One of the most important things is that we actually ask questions about these kind of conditions. And then the importance of support. So other patients, friends, family, and then obviously qualified healthcare professionals. So this is the way that I'm trying to manage it and advance past the disease. And so here's the part where I pitched the SCA and getting involved with kind of this volunteer patient advocacy. I think it's really important for raising awareness, and this is particularly important for young people. It's particularly important for people who are recently diagnosed. Becoming aware of medical research. I think sharing of medical research is important, and understanding what's actually in the field. My background is natural resource sciences, and I think understanding the most up-to-date research is really important for how we deal with things that are affecting us. One of the things that I think I'm going to try to get more involved with is actually advocacy for the medical community. I think, like I'm sorry, your name slips me, but the importance of sharing the information and having that relationship with medical professionals is really important, because who knows better than us with the conditions? Oops, what happened there? Uh-oh. And making research more accessible, making it that it's actually digestible for people is really important, and then helping others like yourself. Well, personally myself, I think sharing between older and younger generations is really important to understand how these diseases actually evolve and how we can start to treat them and manage them effectively. Last two slides of the piece is just advocating that you're not alone. There is a community. We know that about 0.5% have AS. I think 10% of that or something around that also has IBD, such as Crohn's. Support groups do exist, and this is my second plug for the Ottawa group. There's a CSA Facebook group, there's a national Facebook group, and then there's also an Ontario Facebook group. So, you know, I encourage you to get involved with that and ask questions if you have any. Again, Ottawa. And then there is tons of resources out there. So there's the spondylitis website, there's a UK spondylitis website, there's a website in the States. All these resources are there. It's just about getting it and sharing those resources. The last kind of slide is my closing thoughts. Hopefully I went through this relatively quickly. Living well with these illnesses is possible, and it's more than possible. It's very achievable. It's just about practicing your unique strategies. Again, you're not alone, advocating that there is more people around, and we encourage you to get involved, kind of reach out to the community and start sharing. So get involved on Twitter, Facebook, et cetera, et cetera. And the last point is just another thank you to our sponsors. So thank you for listening, and I encourage you to reach out. And so now I have the lucky opportunity of chairing the question period. I'm not sure how we want to do it, but potentially we could use some of the roving mics, or would you guys like to come up here? Yeah, so I've given it to them so they can prep. I would ask them to read the question and then respond to it. We'll try to alternate, and we'll see how many we can get through. So maybe another round of applause for our two healthcare.
So we do have very good questions. One of them is for both of us, actually. Any holistic natural treatment recommendations that you can suggest that have proven beneficial? No, unfortunately not. To be honest, whatever we're suggesting as a medication has a database. So it's provided by the data. So when I'm telling you something, we know to what extent we do see the side effects. So even though I cannot point out if you'll have the side effect, at least we know the frequencies and how that should be prevented or not. That's from the safety issue, which is a major concern why we're giving you something. In terms of the efficacy, to be able to show that something is working, in clinical trials, we always use a placebo control, which means if you give a medication, if you give blinded medications to a patient, and if the patient believes that that's going to work, even though that's not the medication, it's going to work in 1/3 of patients. So it can just be the placebo effect of anything that says it seems to be working. So I'm happy with anything that works for you, but as a physician, I wouldn't be able to suggest using any of them. So I'll go with the second part later.
Okay, I'll start with a question about the passage of ankylosing spondylitis on to subsequent generations. If you do have ankylosing spondylitis, and you're most likely B27. So the question is, what's the risk of passing it to your children? And the risk I use is somewhere between 5 and 10%, maybe a little bit higher. And you can say the same for rheumatoid arthritis and lupus and many other diseases. But I don't want anyone to take away from that is not to have their family. I mean, families are crucial, they're important. I believe some of the medical advances will deal with the problem in subsequent generation in their diseases, if it so happens. But the likelihood of your child having the disease is low, and by all means, please go ahead and have your families.
So the second part of the previous question was, although subjective, is there a critical point when you should return to the rheumatologist after pain gets almost unmanageable? I believe your pain never is supposed to get unmanageable. We should be seeing you before that gets unmanageable. Exactly, if you believe that your pain is increasing, we should be seeing you before it gets unmanageable. However, we may not increase the treatments just based on the pain. As you suggested as well, we're not just relying on subjective measurements. We're trying our best to make it as objective as possible. Because as I was mentioning, pain does not necessarily mean that that's inflammatory arthritis. And probably all of you heard about it before. There's another disease which is called as fibromyalgia. And we don't want to treat your fibromyalgia with biologic agents, increasing the high risk of infections and not having any inflammation at the end. So we have to be very careful to consider increasing the therapies.
So I have a question that deals with the age distribution of arthritis. I believe that's what the intention of the question is. So it really depends on the type of arthritis. And arthritis in general are diseases of young people. Ankylosing spondylitis starts in the teens, 20s. Lupus starts in the 20s to 30s. Rheumatoid arthritis has two peaks in North America, one somewhere between the age of 35 and 45. Psoriatic arthritis can start at any time, but many of our diseases increase with age. So you see more psoriasis after the age of 50, and by the 60s and 70s and 80s, more and more people have skin disease, which means a higher percentage of people will have arthritis. What we're seeing is the accumulation of people as well. We're now living into our 70s and 80s. So we're dealing with new cases, which occur about a tenth at the rate of, so that's incidence, number of new cases per year, and they're being added to the prevalence, number of cases that exist already. As we get older, we're seeing more and more and more and more cases. So we're seeing the accumulation, we're seeing an increased need for doctors, and we're seeing more and more people who need medications. Now it's interesting, the average age of a rheumatoid arthritis study, and just with every study, has been 52. The average age of an ankylosing spondylitis study is in the 40s. Most of us here are in the 60s and 70s. How much information do we have about these drugs in people in their 60s and 70s? Many of the studies taught old people 65. Many of us in this room are well beyond that, and we're considered old for studies. So we now have a new term. We have the elderly, and we have the elderly. And the elderly are people getting over 80. So we're seeing a lot of disease in older people, and we're using the same medications to treat them, and generally we're getting away with it. On top of that, we have degenerative arthritis. And all of us, a good proportion of us in the room probably have low back pain from osteoarthritis. Our hips and knees aren't what they used to be. So that's also adding to the burden. And having one type of arthritis doesn't preclude you from having a second type.
The next question is about smoking. What about secondhand smoke? Does it also increase risk of AS or psoriatic arthritis? I've never run into any data about that. Smoking is complicated to assess because smoking is evaluated like current smoker, past smoker, never smoker, and then we try to analyze the amount of packs smoked per year, so in how many years. And having said that, like current smoker and ex-smoker, if somebody stopped smoking 1 week ago, then the patient is categorized as ex-smoker and not current smoker. So it's really hard to categorize those people. To my understanding, it makes more sense to categorize people as ever smoker, ex plus current smokers. But the secondhand smoking, I assume that would increase the risk because not in rheumatology, but in the other fields, we know that passive smoking is also equally as bad as active smoking. So I would be surprised if this doesn't affect the arthritis pattern, but to the best of my knowledge, we don't have data about that.
I have an interesting question here which deals with the research topic, and that's the cause of ankylosing spondylitis, especially bacterial causes. So we have a very similar disease called reactive arthritis. It's also known as Reiter syndrome, named after Hans Reiter, who described it in soldiers. And it's a reaction. It looks like any seronegative spondyloarthritis, both spinal and peripheral joints, and it occurs after infections, usually GI infections with Salmonella or Shigella, a few other types of infections, and most people are B27 positive. So it's gone on to say, well, if that's the case with those diseases, is there a similar bacteria that causes problems in ankylosing spondylitis? And one of the candidates that has been talked about now for about 40 years is a organism called Klebsiella, which is in the GI tract. The data in support of Klebsiella being the cause is weak. The scientific data is weak, and most of us really don't hold to that. I see someone mentioned a low-starch diet, which may get rid of Klebsiella. Previous attempts at getting rid of Klebsiella with antibiotics were tried without any evidence that it really improved the ankylosing spondylitis. Many things are done, and people do feel better. And so it always seems to be a cause and effect relationship, but I'm not really sure that that's really true, and especially that Klebsiella is the cause. It may be some other bacteria. So Dr. Aydin brought up the concept of the microbiome, which are all the bacteria that live in us. And there is a lot of research being done to really try to understand the relationship of our gut and disease. So I'd like to turn it around a bit. I don't know how many of you are Star Trek fans. Any? So if you remember Star Trek Next Generation, there was a character called Dax, and she carried a symbiote in her body. And that symbiote was a creature that actually gave her all sorts of extra abilities and powers. And it sort of was very important to her existence. We're beginning to look at our microbiome in a similar manner. Conceivably, we're here to really support our gut bacteria. And disease may, in fact, be our gut bacteria saying they don't like us and leading to a number of problems. It's not far-fetched. I think Crohn's disease, there's more and more belief that that's exactly the cause, an impairment or a change in the microbiome. And it may be that that's what's happening in diseases like ankylosing spondylitis as well. So we have to look at our guts more closely.
So for the next question, I'll read the whole question, although the question is at the end, because I think there are really good observations. So everything I've read about PsA says that early diagnosis and aggressive treatment is the key to a good prognosis. Getting a diagnosis, though, is very difficult in my experience, and mine is not unique. Family doctors, GPs don't know enough about PsA to recognize it a lot of the time. So what can be done to raise awareness in GPs, who are the gatekeepers in our system? In parentheses, not to mention shortage of rheumatologists. So to start with the shortage of rheumatologists, unfortunately, it's the same everywhere. I had a chance to work on three different health systems where this was the main issue. So rheumatology is relatively a new field. That's why cardiologists started getting their training years before the rheumatologists started doing that. So it's going to be better eventually. In short term, we have to keep other physicians in the loop. It's not just rheumatology, but all medicine is actively changing. There are new developments in all areas. And for rheumatology, we mostly talked about the treatments, but the diagnoses have significantly changed. What we were using, I've been in the rheumatology for 11 years now, I think. And in the 11 years, what I was doing at the beginning and what I'm doing now is different. And if you're a GP that was trained 20 years ago and needs to update him or herself on everything, is not very easy. So we have to give them training, education, continuous medical education, not very long educations, but to be able to diagnose patients earlier, to get suspicious about some certain diagnoses earlier more easily, and to my perspective, using imaging more often. So imaging doesn't necessarily need to be done by the rheumatologist. It can be done by the GPs and can help to diagnose patients earlier. So I think it's more training.
I've been a rheumatologist for 41 years, and I can tell you the landscape really has changed as to what we can do. There's a question about the balance of drugs, and which drugs you choose and how long you carry on with them has always been a difficult thing, and it really is a relationship between your patient and yourself. There's no drug without risk. Okay? Every drug that we use has some risk, and we try to explain all the risk. No treatment is riskier. Uncontrolled inflammation causes many problems. Uncontrolled inflammation in rheumatoid arthritis, for example, which has been the best studied, takes 5 to 10 years off your life and sometimes more. The rate of heart attacks in people with inflammatory arthritis that's uncontrolled is higher, and it leads to a morbidity about double the other population. So these are diseases that need treatment. You just cannot ignore them. They cause many problems. I mentioned heart is one, but there are many others. But reaching the balance is really a negotiation between me and my patients. Which drugs are you willing to take? Understanding the risk, how to manage the risk, when to call, when to come in, use of other drugs to deal with high blood pressure, and things of that nature. It's always there. The biologic drugs don't have some of the risk of our conventional DMARDs, but they have other issues such as reactivation of tuberculosis, a higher rate of all types of infection. So as I say, it's always a balance. And one question specifically about histoplasmosis. It's a very specific question. We screen for tuberculosis because these drugs can increase reactivation of tuberculosis. Histoplasmosis is a fungal infection which is seen particularly in the Ottawa Valley along the Seaway. And theoretically, we should be cautious with that. So we'd like histoplasmosis to be treated if you've had active. If you're a carrier and you have lung X-ray changes, it's less certain. In the years that I've been doing this, and we've had biologics now for about 20 years, and before that with other drugs, I've yet to see a case of histoplasmosis caused by our drugs. Saying that, people in Arizona, there's a very similar infection, and there have been cases of reactivation of those fungal infections in patients on TNF inhibitors. So again, it's a balance. It depends on needs, and it depends on having a manner of monitoring if one goes ahead.
I love this question. I think this is one of my favorite questions so far. So where are all of the young people at this public forum? The average age of diagnosis is 24 years old, so how can we better inform and engage this demographic? Exactly, that's a perfect question. I'll just give you an example. I invited one of my patients yesterday. I think he absolutely needed to be here. But those people have very young families, and during the day, it's really very difficult for them to come to the hospital. And trying to spare them for the night is also difficult. So this is partially about having less time for themselves. And the other thing is the ignorance. It's really harder to keep the young people in the clinics because they tend to believe that I don't have anything, especially if it's the spine, if it's ankylosing spondylitis, it's not visible. So it's probably nothing. I don't buy it. So that's the usual approach. But we have to keep on talking. And when just physicians keep on talking, it's not as strong as patients talking about it. Because it's a different perspective. So one approach could be that I just thought about going to the universities maybe, trying to go all together with patients and physicians, patients talking about, especially for patients that had the diagnosis with a certain delay, saying that I suffered for 20 years, you shouldn't be suffering. So that could give a good example. And even if they tend to ignore, one by one, they will accept it at the end.
So I'll take this question that has to deal with fatigue in Ankylosing. Actually, it's a very common complaint of all of our patients, whether it's rheumatoid arthritis, lupus, psoriatic arthritis, ankylosing spondylitis. Turns out it's the number one question that people have: do I have anything for fatigue? So unfortunately, I don't. That's specific. Now, what I can say is this fatigue is an example of how patient demands have led to the assessment of fatigue in clinical trials. And there are questionnaires that deal with fatigue. So our drugs show that you can improve fatigue meaningfully or statistically in studies using various scales, but often not to the magnitude that people want. People want to sleep well, wake up feeling well, and not being fatigued. Our drugs help to some degree. In some people, they help more than others. But there isn't another bullet that really gets rid of fatigue. Perhaps exercise, getting better, using that as a way of getting to sleep may be a bit of help, but I haven't got another medication for it.
There's one question. I had a small melanoma on my leg 4 years ago, removed, no chemo, no radiation, but I've been told biologics are not a good idea. What other options are available? I'm on Celebrex, Plaquenil, methotrexate, leflunomide. I have psoriatic arthritis, both knees replaced, not age 60 yet, disease is severe. So safety is a major concern with biologics, so we have to take all the precautions not to increase the risk of malignancies. And the prior history of malignancy is a major concern, like the melanoma, even though it's treated. So for the anti-TNF medications, for example, we have strict guidelines to guide us to whether or not to be able to use. For the other medications, such as I was given it at the end as an example, the new oral type of medications, apremilast, is an option, which seems to be relatively safe, meaning placebo-controlled trials do not show increased risk of future development of malignancies. It seems to be better than the anti-TNFs, but it's a very short-term trial yet, so we don't have the very long-term extensions of the studies. So the experience with the anti-TNFs is much more longer compared to those ones. And we don't have any data on, to the best of my knowledge, we don't know any data on if somebody had a prior malignancy, can we use that? So it's not data-driven. That seems to be the safest option. On the other hand, sulfasalazine, if it's not tried before, it can still be added on the combination, and injections, the joint injections are always a good choice.
Okay, so maybe one last one. There's one on ankylosing spondylitis and Crohn's. I don't know if it was you who wrote it or so, but asking about the medication. So when both are present, the TNF inhibitor tends to be the drug of choice, except we don't use Enbrel because it doesn't really work in Crohn's. So it would be Humira, adalimumab, or Remicade, infliximab. I can't think right now if there's been any data with the other TNF inhibitors, Cimzia or Simponidalimumab and Crohn's. I don't think they're being used. Interestingly, a drug used for psoriasis, ustekinumab or Stelara, is actually currently in trials for Crohn's and may be actually quite good for Crohn's, but it doesn't, as far as I know, have any evidence dealing with the arthritis part. So if someone has gut and arthritis, either Humira or Remicade would be the drug of choice for you.
And my last question is two parts. I'll start with the second part. I love the first one, so I'll save the best for the last. So methotrexate, how long to work, show improvement? So if I get it right, how long does it take it to work? It takes about 6 to 8 weeks, I would say 3 months to be able to see the response. When I see a patient in the clinic saying in 3 months, I did see a response, I'm not fully covered yet, I would still wait a little bit more because there may be a little bit of better response over time. If I don't see any response in 3 months, I would question the dose that I was giving. Maybe we need to increase the dose if there is still a room on there. And we may change the route as well. Like if I'm using the oral medication, we may need to go to the injection form, which could be better. So that's one way to deal with it. And the other part is psoriatic arthritis registry, how to register. That's a perfect question. I wasn't prepared for it, but I think there must be a way to share our information with them so that they can get in touch with us. I don't know how to send information out though, but.
Yeah, great question. Maybe we'll.
How can we announce?
Pardon?
How can we announce how to get in touch with us?
Yeah, well, why don't we can write it quickly, your emails, and then provide it that way. Maybe we can write your email down.
I'll correct my surname.
Sorry.
So mine would be the same, except the name.
That was my last question.
Great. So I will have to wrap it up. We've stayed long enough for everybody, I think. So I think one more round of applause for our lovely doctors and presenters. And a round of applause for everybody who came. So, we're really happy that you came out. So thank you. Get in touch. I encourage you to fill out your evaluation forms. You can leave them on the desk as you're leaving and stay in touch with both the Arthritis Society and CSA. Safe journey home, and thank you.
Thank you.